let's do a case study. So this is your bonus. So in addition to giving you all these hacks, OrthoSecret hacks, I wanted to do a case study because a lot of the complaints that I get is, well, I don't have any experience. I don't know what to do. That's why I'm sending ortho. Well, I guess the question that I want to pose out there is, how can a nurse practitioner who lacks, nurse practitioner or for any matter, anyone else managing these kind of patients, a physician or PAs, who lacks orthopedic experience, ace that orthopedic consultation, right? How can that be? And I want to ask you first, though, is it okay with you that I use the When to Consult OrthoSecret ebook that I created? There I have all the checklists and it'll be very useful for this case study. Yeah? All right, let's do it. So, how does a nurse practitioner go from not knowing when to consult orthopedics to confidently knowing when it is the right time to request that consult? Well, my student Amy did it, and I am more than 100% that you can too. So here's how. Let me show you. But first, I want you to put yourself in the shoes of a brand new clinician who is uncomfortable managing common ortho conditions. Okay? So in her case, in Amy's case, one of her patients showed up with severe knee pain after a knee injury the week prior while the patient was doing martial arts. And this patient was not able to bear weight, and the main complaint was that the knee was giving way. Well, with what we went through, the same training, Amy knew that the right questions to ask needed to be old cards, right? Using that framework. And these high yield questions, they helped her narrow her diagnoses. And then she moved on to step number 3, where it's like ruling out emergencies, right? Well, in this case, an ACL tear is a big deal, but it depends on what on the patient that you have in front of you. So like we talked about, right? In this case, her patient actually reported trauma. The knee is swollen with a lot of pain. Actually, the pain was out of proportion when the patient was weight bearing and the knee was giving way. So she felt a little guilty because she lacked, in-depth training for ortho. But the patient was in her clinic and the patient was in front of her, so she had to figure it out. She told me that her colleagues were busy. She also didn't really want to seem like she didn't know how to manage this issue. And by the way, just these are all real feelings, guys. And it's feedback that I get from all my students that I've trained, and I felt like that too. So there's nothing to be ashamed of this. We have all been there. So this is very normal. So then she moved to step number 4, the focused physical exam, but the knee was very painful with active range of motion, and it was swollen, and the exam was just very limited, right, because of the pain. Now let's help Amy. I want you to help me help Amy, and let's take a moment and write what you think is your differential diagnosis if you were in her shoes with all this information. So you can write that down. Maybe you can use secret number 7 to write that down. So I'll give you a minute there, a little bit. You can pause and then come back. But if you guessed right, the answer is an ACL tear. And if you think that's what it was, you're on the right track. But let's say that you're not sure where to start or even how to manage a patient like this appropriately. Well, Amy used the clinical decision-making tool that she got from me, and that's the one that I told you that I was going to show you. So let's see. Okay, let's take a look right here. So I decided to have all the most common diagnoses on the sidebar. So I created this sidebar right here, where it has the intro, the table of contents with all the 7 chapters, right? And here I'm gonna share with you. I don't typically do this, but I'm gonna do it today because it has all of the common like knee diagnoses that typically present to the clinic. Okay, so based in our scenario, you can come here with when you have this tool and just open. You can have this on your desktop. You can have it on your phone, iPad. And in her case, she had the suspicion that it was an ACL tear, right? So she clicked on that. And then right there, in less than a minute, you know what to do, whether to treat this patient non-op or send the patient out. So let's take a look. So conservative management, who is it appropriate for? Well, patients with low activity level. So our older patients older than 50 plus. Not that a 50-year-old is low activity, but typically these patients will not really be fixed by the surgeon with an ACL. And another key is when they have less than 5 millimeter of laxity. So if there's more laxity, definitely that would merit a consultation. And you know that when you compare the injured knee to the uninjured side. And also patients that you pick up that ACL tear, but they also have advanced or end stage arthritis. There's nothing to do for the ACL, guys. That's part of the arthritic process. So these are not really surgical candidates for like an ACL repair, and you can continue to proceed with conservative treatment, including some bracing. Or patients that are just not interested, right, in any surgical management. Now, who is surgical management for? Well, this is for patients who are younger, patients with symptomatic instability, that do not have arthritis, and that want to continue their sports-related activities. So marathon runners and patients who are just really active and are young, like, yes, like, especially if it was like recent trauma, you definitely want to get them through. And also like patients with a lot of laxity when you're doing the exam. So the next thing is like, okay, so how do I determine, right? So let's look at the checklist. Well, is the patient older than 50? Well, let's rule out first that the patient doesn't have osteoarthritis. If the patient is younger, then let's get the MRI because you're considering that ACL injury. The patient has unresolved knee instability symptoms, yes. And also, how optimized for surgery is this patient? This is things that you need to think about. If this patient has, let's say, uncontrolled diabetes, and the diabetes is, I don't know, a hemoglobin A1C of like 10, I don't think that a surgeon is going to go and fix that, because the risk of this not healing is very, very high. Also, if the patient is a smoker or a substance abuser, I mean, these are all things that will make the surgery not have pretty good outcomes. So if that's the case, then PMR can also be a good option to send the patient to, put the patient on the brace, consider optimizing and modifying all these risk factors. But otherwise, consult the orthopedic surgeon. All right. So there you have it. We just went over briefly how to like triage and manage like this kind of situation. There you have it. Again, this is not everything that you need to know about ortho, but it's a great start. It's a great foundation, especially if you work in primary care and handle these patients with ortho complaints. If you apply this, I promise that it can push the needle forward and can help you and have a huge impact on your daily clinical practice and your life, and hopefully get you home a lot sooner than later. And last thing, just make sure that you save all your notes in the one-pager app, or if you are on the computer, save the page, so that then you can go back and you can access all the notes, and that you can continue to make this a practice and to apply this daily. I really hope that it can have a huge impact on you, and even more on the patients that you treat every single day. That's why I've taken the time to do this work for you. Okay? Until next time.